evening. I will be discussing on bradyarrhythmias today, a case-based approach. At the scope of discussion, I will be discussing the theory very little and will be going to interactive section with ECG very fast. And bradycardia is defined as the heart rate always less than 60. And this always less than 60 may be and if it is in a pathological state, it can be due to disorders of impulse generation from the SA node or its conduction down the line from SA node to AV node to his bundle and bundle branches and Purkinje system. And as you all know, the patient who is having a bradycardia, whose heart rate is 40 or 50, whether he is really in trouble due to that low heart rate, you want to assess. Then only the next step of management treatment comes. Some of the people who is having a very sportsman, very active physically, will have a heart rate around 45, 50 like that. In that patient, it's not bradycardia is physiological only. But in some patients, that 40, 50 will be, they will be in symptom. They will have fatigue or they will have giddiness and all those things. So all bradycardia patient you should identify, you should clinically examine, and you should acute causes of bradycardia should be ruled out. What are the possible causes of acute bradycardia? Usually we will see patient before a respiratory arrest will become bradycardia and then go to cardiac arrest. So most common is hypoxia, that is acute severe asthma or in COPD, or patient who is having severe acidosis, metabolic acidosis also, they are going to be in bradycardia and just before that cardiac arrest happens. Then hyperkalemia, you all know that. Hypothermia, that is a most common thing usually we see when a patient is arrested and his body temperature is reduced to preserve the brain function. In that case, for patient in ECMO, if you reduce the temperature to 30, core temperature 35, you usually see hypothermia. In that hypothermia, you usually see J waves. And usually the heart block, acute heart block. Usually acute heart block we see in inferior wall MI and in complete heart block due to degenerative congestion disease that decompensated very fastly. And toxins, usually will bradycardia, that digitalis or toxin, digitalis toxin, botulinum poisoning, all those things comes with heart block. And the toxins. Then drugs also, high beta blocker and antiarrhythmics in high doses, they ingested for cerebrals and farm can have this acute bradycardia symptomatic. And trauma also. Due to this may cause hyperkalemia due to crush injury, and that causes bradycardia and cardiac arrest. So assess all ACLS, you assess all those things clinically and clinically assess the patient for his mentation. You should be, and his blood pressure, cold calming peripheries, and decreased urine output. It's like a short presentation with a low cardiac output, low heart rate. Is a bradycardia, something to be urgently addressed. In that case, first initial recitation guidelines telling for bradycardia symptomatic, give atropine 0.5 milligram dose, bolus dose up to 3 doses to 1.5 grams. And if it non-responsive, start dopamine or isoprene. And then if these measures not responding, then you should connect the patient to the transcutaneous temporary pacing or intracardiac temporary pacing for the life-saving measures. First, always rule out the possible causes first. This is the restoration pattern and the method to identify the patient who is troubled with bradycardia. Most of the patient who is coming to OPD and having bradycardia usually will not have these problems. So the classification is the sinus node dysfunction. From at the level of sinus node, this bradycardia can be due to sinus bradycardia. Usually, as you all know, this can be drug effect or can be autonomic increased vagal tone and SA exit block. That first degree, second degree, and third degree, we can see diagnose only second degree SA exit block in ECG. First degree and third degree, we can't diagnose in surface ECG. And from that SI node, the atria is the conducting tissue. So in the atrial level, if its blocks happens, we call it as atrial standstill. SI node is firing, but atria is unable to conduct and inexcitable. In that case, we'll do atrial standstill. And AV nodal level, from AV node, that's the conduction pathway. The effect in conduction, in that is AV nodal first degree, second degree, third degree. We will see the ECGs. So the ECG approach to any bradycardia should be very systematic, and a beat-to-beat analysis is needed. And the analysis of all bit, the P wave, the morphology of the P wave is very important. Axis of the P wave is also important. Morphology, normal P wave will be positive in 1, 2, and negative in AVR. Negative in AVR. This is, and normal P wave axis around 70, 0 to 70, 70 to 75, 70 to 75. That is normal P wave axis. When the SI node fires, P wave axis should be normal. It is positive in 1 and 2, and it will be negative in AVR. And the PR interval usually in physiological range will be 200 millisecond. That always the PAV atria to ventricular relationship, that is every P there should be a QRS should be there in a normal conducting heart. And that QRS should normal conductor. So the sinus node fires and atria conducts, and all the impulse converges to the AV node from with the normal physiological AV delay. There inscribes a PR interval of 200 millisecond. Then it will goes to bundle of his. Then it goes to bundle branches and to the Purkinje system, and the entire ventricle depolarizes. This entire thing will be in the QRS, and then it depolarizes to form the T wave. So this is the pattern of activation of the heart. So then every P should be accompanied by QRS. And when there is no P wave, we should thoroughly look for escape beat, and what is where is the escape beat is coming from. And on the fibrillatory beats, if fibrillatory waves are there, it can be atrial fibrillation. And the impulse from this way, you have to see from where the impulse originates, which way it is going, and from how it's depolarizes the ventricle and repolarizes finally. So if anywhere this block you find out, you should determine whether it is proximal to his bundle, that is between SI node and AV node, and distal to his bundle. In distal to his bundle is a ventricular rhythm that is always considered as unstable. So the patient may decompensate fast. So localizing a little bit is also very important for prognostication of the bradycardia. So we'll go to the ECGs. Can you tell what is the? Can you first we will systematically analyze this ECG, and we will find out what is the problem. If there is any problem, then we will go one by one, case by case. After this, only till 28 ECGs are there. If we go very fast, we will see maximum number of bradyarrhythmia issues that we come clinically usually miss also. If you know only about these things, you will be able to recognize it. Most of the patient will be asymptomatic. That's why missing a bradycardia will not be a problem at the initial phase. But if the disease is progressing, they will be finding patient presenting with a later unstable state. So anyone volunteer about the findings? First case, we will go systematically one by one, how it goes in a bradycardia case. Then we will go fast with the diagnosis center. This is a simple ECG. Can anyone tell the diagnosis? This is a normal, so actually very easy one. Hello?
Participants can unmute and answer.
Most of the rarest ECGs I took from Mukund Professor, associate professor in CIP, electrophysiologist. Most of the people may be knowing him. He's very interested in ECGs. He studied in Calicut Medical College. Now he's in Manipal. He's having a very interesting collection of ECGs.
Minus bradycardia, ventricular rate around 36 per minute. Normal axis, T inversion in 1 AVL, V2 to V6. Possibility of an HCM should be considered. Probably patient is on beta blocker.
Yeah, correct. This is sinus bradycardia, left ventricular hypertrophy. Can be considered hypertension, systemic hypertension, left ventricular hypertrophy, and due to drug, there is sinus bradycardia. That's all. This ECG is that much. This T inversions, how is it? Is it ischemic or non-ischemic? As we learned from last time. This is asymmetric T inversion. So it's a non-ischemic T inversion. This is another case of 34-year-old lady, healthy lady. Cardiac evaluation, she found her irregular heart rate and ordered for an ECG. What is the finding? This is a healthy lady, no symptoms. Just during health checkup, you found out a regular heartbeat. So how will you diagnose this most common thing we usually seen in OPD? And especially seen in young kids who are saying between 5 to 10 years. So you will be referring for irregular heart for evaluation to cardiologist. So
possible sinus arrhythmia.
Yes. When will you tell it's sinus arrhythmia? What are the hard findings you tell you about this? This is sinus arrhythmia, not nothing else. Not sinus, sick sinus or sinus exit block. Usually, sinus exit block versus sinus arrhythmia is the question. This also will have this. What is sinus arrhythmia? How it occurs? Sinus arrhythmia is usually respirophasic. With inspiration, heart rate goes up. With expiration, heart rate goes up. Inspiration, heart rate slows down. So in this rhythm ECG, if you see every PR, P is followed by QRS, and there is PR interval is fixed. There is no variation in PR interval, and there is RR variation. And this is the least. This is around 200. This is 600 millisecond between two RR interval, and the largest is being this one 1, 2, 3, 4, 5. So this is around 1000. This is around more than 1200. 1100. The millisecond is the largest RR interval. So the smallest to the largest RR interval is more than 400 millisecond. Usually, with the constant PR interval and and 1-to-1 AV conduction is usually suggestive of a sinus arrhythmia, almost always. And this is there is no pathology in that. It's very high due to the respirophasic variation and autonomic function, optimal autonomic function. This is mainly seen in babies, and this clinically palpable as irregular heart rate, mainly respirophasic. It's not beat to beat. And this is another ECG, 42-year-old referred as irregular beat. Is it sinus arrhythmia? You can only see the lead to long rhythm strip for EC assessment, and ideally you should see all the beats, P followed by QRS, PR interval, PP interval, RR interval, everything, and a QRS morphology, ST segments and T waves. Then only the assessment of the entire ECG will be proper. Can anyone read this ECG? No need of telling any diagnosis to this ECG. Is it sinus arrhythmia? That's the first question. Sinus arrhythmia, always you should think of a possibility of SC exit block also. So this sinus arrhythmia you already know. This PP, this RR interval varies, PR is constant. But in this ECG, can anyone read the ECG? I think don't have to give the diagnosis for this. This is a grouped beating actually. Grouped beating. You are seeing QRSS, 3 QRSS in groups. So grouped beating always in a patient usually indicates SA exit blocks. This is a case of SA exit block. In which type if you want to see, you have to see between PP intervals. If the PP interval gradually coming down, shortens, this is one P, this is another P, there will be around 600 millisecond between this. This is the P and this is the P. In between this, there is little shorter than that to this 500, maybe 480 milliseconds. So there is shortening of PP interval. This P, and there is a non-conducted. Then there is no absent. There is absent P. So this is a shortening of PP, and there is a pause, and the pause is not the exact multiple of PP interval. So this is a exit block. So in a grouped beating with the PP interval, gradual shortening of PP interval, usually this is exit block, Morbitz type 1 block. This, you will be knowing AV block type Morbitz 1 and 2, gradual prolongation of PR interval and shortening of RR interval. In this case, in this, when it's applied to the SA exit blocks, only second degree we can identify an ECG. In that Morbitz type 1, PP, there is PP interval, there is gradual reduction in PP interval, and the pause will not be the multiple of PP interval. This is a SA nodal exit block. If you see a grouped beating, this is a chance of SA exit block, but this rolls out a sinus arrhythmia, because respiratory failure is not respiratophasic variation. This is a 70-year-old patient with giddiness episodes, diagnosis, and how will you investigate further? What is the diagnosis? Here also you're seeing grouped beat. So it can be what? Anyone tell you read the ECG? Here a PP interval, any changing? Can focus on the PP interval. Then you focus on the pause. And PR interval also you should see. Can anyone tell? Here any gradual decrement in PP interval, any reduction?
No.
There is no, unlike the last ECG, this is a fixed PP interval. And after that one P is missed, but the missed PP interval, before the this PP interval, this missed PP interval is exact multiple. So it's like a second degree Morbitz type 2 block, a exit block. These two only will be knowing by surface ECG. So then there is a grouped beating with a maintained P to QRS relation, and there is no fixed PP interval. This can be exit block Morbitz 2. Okay, last one had a reduction, decline in PP. First long PP interval, second PP interval will be lesser than that, and the pause will be not be exact multiple. Here the pause will be exact multiple of the PP interval, and there is no decline in PP interval. So this is the exit block. When you all these two, you'll see grouped beating. So when you see in clusters 3, 4 like that, you should bear in mind that this is a possibility. Say exit block. This is a harbinger of sinus sick sinus syndrome in old people. So you should ask for a Holter testing. Holter this 24 or 72 hours Holter study to find out any significant pauses or any other arrhythmias, so that you can explain the cause of giddiness in this patient. So these two are the harbinger of sick sinus syndrome. This ECG 62 years gentleman after bypass surgery is on bisoprolol, and he came to OPD. He doesn't have any symptoms. He's doing well. After waiting for so long, he came to OPD and we took an ECG and find out. Can anyone tell this about the ECG? Can see the search for the P wave PR relation, the P wave morphology, QRS ST segment. Is it bradycardia or when this is bradycardia, and this is mainly there is no P wave. Usually in between there is some P wave to the QRS. About that P wave is negative, so this is not coming from the SA node. That P wave is negative in to AVR, it is positive. So normal P wave is AVR is negative and 1 and 2 will be positive. So in this P wave is not belongs to the SA node, and there is no P wave prior to these complexes, QRS complexes, and this QRS complex is narrow. The narrow QRS complexes are coming from either from atria conducted through the his bundle to the Purkinje system, and or it can from the junctional area, junctional rhythm. Junctional rhythm also will be narrow stable rhythm. So there is no preceding P waves, means this is a junctional escape beat. Junctional escape beat. This is all the junctional escape beat is coming at the rate of around 40 in this patient, and you are seeing there is an beat coming, but there is this PR interval is around 80 milliseconds, very short PR interval. So this is this P wave is not coming from the junction, not conducted down. That P is fired, but the junctional rhythm is more faster, so it took over the it's overdrive the it's come faster than the SA node, so the SA node is not firing. But this patient we have to see what happened to this patient. So this patient you just to make him this patient doesn't have any syncope or any giddiness, so just make him walk or and take an ECG. His sinus rhythm will take over, and usually if heart rates increase, then only you take a next ECG. Then we will be knowing that whether it is significant SA nodal disease or conductional disease or just a vagatonia causing these things. This patient actually we make him walk, and his ECG sinus rhythm took over and his rate increased. So these kind of conduction system problems like increased vagatonia we can see with the suppressed SA nodal activity due to beta blocker. So just make the patient either do treadmill testing or just make him walk or stand. And then if we took ECG, if the sinus rhythm will pick up and the vagatonia will be taken away. So in that case, we can simple test. We can rule out whether this is a conduction system disease or just a vagatonia and or a beta blocker effect. So this patient made to walk, then to walk a little fast and get an repeat ECG, and his rhythm picked up, sinus rhythm. So vagatonia is another thing you should bear in mind. This sinus slowing with some junctional beat within an asymptomatic patient. This is a 78-year-old ECG came in the ward with during LRT admission. What is the diagnosis. Can anyone tell the diagnosis? Read the ECG. Tell the diagnosis. This is the same thing this just now I mentioned. Is this the P wave belongs produce the QRS or not? Is it possible to have such a small PR interval for this QRS, or is a junctional beat with independent sinus node firing but not conducted? What is the possibility, and then what is the name for this phenomenon? This is a classic ECG. You can see. Sometimes we will see in wards also, but we will be unable to identify it. Is it indicate anything? Can anyone tell? This in this ECG, if you see the lead 2, this P wave, this P short PR is so short. This PR is so short. This P is marching into the QRS like that. This is in this case, this QRS is not conduct from not from the P wave fired from the SA node. This P wave is fired, and then the junction is fired. So the P wave and junction is competing. There is so this is a type of AV dissociation, isoarrhythmic AV dissociation. In this, atria fires, junction fires, both at the same time or a little bit later or after that, and but equal amount of ventricular beats from the junction and atrial beats. So this is a isoarrhythmic AV dissociation. This is also a pre-runner of the sixth sinus syndrome. So this P wave is not producing this QRS. This is from the junction firing. This is from the SA nodal firing. This is so this is independent. Atria is firing independently. Ventricle is firing independently. So it's the form of AV dissociation, and atria and ventricular both are the same number. So this is isoarrhythmic AV dissociation, usually seen in older people with a high vagal tone, and they are having a possibility of sixth sinus syndrome also. So this is a form of AV dissociation. This is a case 76-year-old multiple episode of arrhythmic syncope. Arrhythmic syncope is sudden brief episode of syncope, usually without any prodrome, and patient regains consciousness very fast during this episode. Can anyone tell the Holter finding in this ECG? What is this phenomena? And the patient will have sudden loss of consciousness if this occurs.
Tachybrady syndrome with Stokes-Adams attacks.
Yes, it's correct. This is a sinus arrest. Sinus arrest means sinus node is not either sinus node is not firing, or whatever sinus nodes fire due to exit block, third degree exit block is not conducted to the AV node. So this is a typical thing of as a sinus arrest, and with a prolonged pause. In between there is no systole. So in between there is no cerebral ventricular contraction happens. Blood flow to the cerebral circulation comes down, and the patient will have a brief episode of syncope. So then when the QRS regains junction this is followed. This is followed by junctional escape beat. When there is a pause, the beat comes after that prolonged pause is a escape beat, and this escape beat is narrow, so it's coming from the junction. So it's a sinus arrest is junctional escape, and when the heart rate increases, the patient will have adequate cerebral circulation, and he will usually come out of the syncope without any problem. This is the tachybrady syndrome, typical stroke attacks. So, cause of syncope in elderly. Very rare to have fatal bradycardia, but usually they will have symptomatic bradycardia with falls and those problems. So these are treated with mainly with the permanent pacemaker implantation. For the time being, if PPI is not available and they are having recurrent syncope, we can give them on isopranaline oral tablets 10 milligram and or darifilin, pentoxifilin tablets, but not pentoxifilin, theophylline tablets to increase the sinus nodal activity and hold the drugs which causes sinus nodal or AV nodal suppression. But usually this patient needs pacing. What is the diagnosis? But another cause of long pauses also you should know. Any diagnosis? This is an elderly patient who came with an arrhythmia initially, and we diagnosed it as atrial flutter, and we started on amiodarone and sent home. At home, he had multiple episodes of syncope. So, in this, what is the cause of this pause in this patient? This is same sick sinus syndrome with a large pause, but in this patient, there is a peculiarity for this pause. Can you tell about it? There is a wave like sawtooth wave like in the upper strip, and this tachycardia terminates here due to the drug or spontaneous termination. Then the sinus node doesn't recover. It's a sick sinus node, and after long pause, the sinus fires and the QR is coming. So this is a termination pause. When when the tachycardia like atrial flutter or atrial fibrillation who is going on with a fast rhythm, fast way, fast rate. In that case, if you modify with amiodarone in patient who is having a sick sinus syndrome, tachybrady syndrome, in that patient, if the tachycardia terminates to sinus node, sinus rhythm, the next sinus is sick. So the next sinus firing not happen due to the sinus arrest, and the prolonged pause happens till the junctional escape or the sinus firing comes. So this patient can have a syncope due to the termination of tachycardia. This is another one form of tachycardia, one form of pause that can happen in a patient who started recently on antiarrhythmic drugs have a syncope. So this is this case you should be knowing because you recently started drugs syncope. Then you should. This is a possibility usually. Can anyone tell about the ECG? 40-year-old resting cardiomyopathy with stroke. ECG. Can anyone describe the ECG? Salient findings in ECG, only single word. Don't have to tell the diagnosis. One. There is any P wave is there?
No.
There is absent P wave. There is sinus. Then there is a junctional escape. There is slow junctional escape, and there is any fibrillatory wave. Anything? This is actually a flat line coming in the between the RR interval. This actually in a restricted cardiomyopathy patient with this ECG and with history of stroke, embolic stroke. This is atrial standstill. Means atria is inexcitable. It's a sinus node may be firing, but atria is not capturing, not exciting. So this is a high risk for stroke. This is atrial standstill. Now from the SA nodal level, we are going to AV nodal level. From SA nodal level, what we see in SA nodal level, sinus bradycardia is there. Then sinus arrhythmia is there. Then exit blocks are there. Exit block only we can see second degree only we can see in ECG. Second degree Morbus type 1 and type 2. In type 1 we will see we can see the decrement in PP interval comes down progressively, and the pause is not the multiple of the PP interval, smallest PP interval, and then second degree Morbus type 2 second degree block. As exit block will have fixed PP interval, and the pause will be the exact multiple of that PP interval. And then we saw junctional junctional rhythm due to vagatonia, the junction takeovers, isorhythmic AV dissociation, junctional rhythm. Now atrial standstill. Till here, these blocks can happen in atria in SA nodal level, atrial level, AV nodal, and junctional. AV nodal mainly due to vagatonia usually and drug effect. Now from here, we will go to the AV nodal level of AV nodes. Can you see this is easy thing usually we see in daily routine. Can anyone tell the diagnosis and read the ECG and tell the diagnosis? You should read the ECG. You should see the P wave axis mainly 1, 2 AVR, then PR interval, QRS axis duration, ST segment, T wave, QT interval, like that. This is the way you should read a tachycardia, means bradycardia ECG. Of course, in the rhythm strip, all beats one by one we have to see. What is the diagnosis in this ECG? It's very easy ECG. Can anyone tell the ECG?
First degree heart block.
Yes, correct. What is the PR interval in this patient?
Almost 0.6 seconds.
0.6. Oh, yes. Yeah. So this is a 300, it's around 200. Yes. It's a very large. This patient will have any symptoms because of AV dysynchrony. Because ventricle will be contracting against the closed atria, so they will have some form of ventricular dysynchrony, and some patient it will become dyspneic during exertion. Otherwise, this is a benign entity, first degree AV block. Okay, next one. This is the next to that. 43-year-old with history of CAD on beta blocker. What is the diagnosis? First we see first degree. Now we will go to see second degree Morbus type 1. What is the catch in this? This is usually we will be able to find out a Vengi back very easily. But in this ECG will give a doubt whether it is Vengi back. But what is the most important thing? I tell you it's a Vengi backing. Morbus type 1, second degree AV block. What is observation usually? This PR is prolonged definitely, and as the PR is there is some prolongation of the PR interval, very minute only. And after the prolonged PR interval, there is a P wave not conducted, and after that pause, whatever P wave is conducting will be the shortest, with the shortest PR interval as compared to the beat prior to the non-conducted P. So this is the largest PR. This is the shortest PR. Shortest PR is coming after the missed P. And there will be gradual prolongation of the P wave, and there will be gradual reduction in the RR interval. RR will be gradually reducing. In this is subtle only, but it's reducing. These four things will define the Venki backing phenomena or Mobitz type 1 in second degree AV block. So gradual prolongation of PR interval and decrease in RR interval, and this every after one PR, the increment in PR interval will be decremental. That is, first PR interval will be 400, second PR, first PR 236, maybe 240. Next, it will be 260. Then it increased by 20. And the third one will not increase by 20. It will increase only by 10. That is the increment is decremental, like that is telling, because if this is increasing by 40, the last bit will not increase by 40. It will increase by only 20 or 30. That is the increment in PR is decremental, and decrease in RR interval, and the beat after the non-conducted P will be the shortest PR. These four things comes, then it is Venki backing or Mobitz type 1 second degree AV block. This is also physiological thing. This up till now there is whatever the type 1 and type 2 Mobitz 1 Venki backing is physiological. This can happen physiologically and can be reverted, not indicating any conduction system serious conduction system disease. So these patient needs only modification of the beta blocker. So there is slight increase in PR interval, reduction in RR interval. There is prolongation of PR interval in successive beats. That prolongation absolute value will be decreasing, and the beat PR interval after the missed non-conducted P will be the shortest. These four things needed for diagnosing Venki backing. So anyone from here onwards, we will be seeing a little more serious arrhythmias, non-bradyarrhythmias needing urgent care, urgent evaluation, and may need device therapy. So in this patient, 56-year-old man, pre-evaluation of cancer surgery. And how will you evaluate this patient and recommend the surgery? Can anyone attempt the thing? This diagnosis is clear in this patient. What is the P to QRS relation? Every P has a QRS or not?
No.
No. What will be the block visit? Till now we see Mobitz type 1 second degree. So obviously by going order we will be seeing this one as Mobitz type 2. So this will be what kind of arrhythmia? Is it what kind of AV block? Is the P to QRS relation maintained? There is non-conducted QRS. Not
Yes.
P to QRS, whatever P conducted QRS is P to QRS. And there is at least this 2 P is not conducted. This one, there is a P in this T. When a P falls on T, there will be morphological change happening to T. It will be more pointed sharp, because P wave have definite height and duration, ascent and descent. So that will be inscribed in the T wave. T wave usually will be very flat. When a P wave falls on this T wave, the T wave will become more pointy and more tall. So you can definitely see this T wave. All T waves are more pointed and asymmetrical. So there is something false on that. This actually this P wave is falling over that. So for this 2, 1, 2, every third P wave is conducted. That P wave is conducted to the sinus node. SA node, AV node to the. So this is a category. There is okay. This is a narrow QRS. So this is a second degree Thymorbis 2 block. With how will you manage this case? This guy doesn't have any symptoms. He came for a cancer surgery. Can you send him for cancer surgery or need a pacemaker prior to it? This is a relatively narrow QRS, stable rhythm without symptoms. We can, but under cardiology service hospital only we can send for surgery this patient. Usually the people will come out of surgery without any problem, and later electively we can offer a pacemaker to these patients. Because the evaluation of the patient with AV blocks, we can assess the patient risk by assessing the QRS level of block, the QRS. So the next case, what's the diagnosis in this case? Is this a normal sinus rhythm or
Type 2 AV block with RBBB.
type 2 AV block, 2:1 AV block. Morbid's type 2, correct. 2:1 AV block. In this, you all see that this T wave end, there is a positive thing. Like this only P waves will come in like this. 2:1 AV block with RBB. When the escape, this is escape, ventricular escape. When the ventricular escape duration increases like RBB, LBB, or this is unstable rhythm. This patient who's having hernia surgery can undergo pacemaker first because he had a fall. He's symptomatic also. Seizures. So seizure may be due to the high grade AV block occurring in between. So this patient, you should prioritize his stable. He's a wide QRS escape. 2:1 AV block can progress to complete heart block anytime with a wide QRS right bundle branch block ventricular escape. Should be prioritized for pacemaker than for a hernia surgery like elective surgeries. So the cancer surgery is semi-urgent surgery. So that patient can be cleared with narrow QRS and relatively asymptomatic status. But this patient who is having wide QRS, symptomatic with the elective surgery, go for a pacemaker implantation first, followed by surgery. And 68-year-old with history of exertion, dyspnea, and syncope. What is the diagnosis? This is a classic diagnosis. You usually will not miss it. And you have to tell the 4 criteria to diagnose. Is a common finding. Usually we see 4 things you have to tell whether it is that diagnosis. We should already see 4 things in second degree Thymorbis type 1. Venky bagging criteria, 4 things are there. And this one also, this is third degree heart block, complete heart block. So how will you tell this is a complete heart block? There are 4 things to tell about this is a complete heart block. If 4 things are there, it will be complete heart block. Some exception will be there, but usually it will be like that. And from subsequent ECG, from here we will be seeing some of the complete heart block cases with some clue to the severity of the disease, some clue to how to clue for a patient with you will be always seeing complete heart block patients. For some people are doing well even if they're not doing any pacemaker. They will have a complete heart block on ECG, and some people, if you have complete heart block, if you try to keep on medical management, they will have heart failure, sudden syncope, or someone die suddenly at home. So we'll be seeing what all things in the ECG will tell you these people are okay. But complete heart block, there is no medical management. You should tell them about the pacing strategies. That is the treatment of choice. But some of them can be on medical management, and some in very different types, specific sets, and some with very subtle ECG findings, but they need to undergo pacing as early because that will be high risk for sudden cardiac death. We will see one is from here we will be seeing complete heart block ECGs with some of those findings. Can anyone tell why it is complete heart block? Why it is called complete heart block? This ECG. In this ECG, if you see the lead 2, you can see there's fixed RR interval. This is RR interval. In this RR interval, right? Sorry, not RR. PP interval. PP interval. This is around 150. All PPs. This is P. This is P. This PP is around 150. This P to this P is 150. Here is 1P and to 1P. This is 150. You can see this T wave, this and this T wave morphology is different. This T wave morphology is different. This so whenever T wave morphology changes beat to beat, or T wave height changes beat to beat, or T wave is more pointed, then it can be P wave falling in that T wave. So the P wave, there is a fixed rate to the 150 rate to the atria. There is a constant PP interval, and this RR interval is 1, 2, 3, 4, 5, 6 squares. 1, 2, 3, 4, 5, 6 squares. So RR interval is also fixed. So regular PP, regular RR, and P to R relation is not maintained. This P is not related to R. This P is not related to this R. This P is not related. So there is dissociation of atria and ventricle. So AV dissociation, plus one more thing. There is more A wave than V wave. That is fourth one. This here, this is 150, and this is around to 50. Ventricular rate is 50 and atrial rate is 150. So atrial rate is more than ventricular rate. So this is another type of AV dissociation. That is complete heart block. So the three things: regular RR, regular PP. There is P not related to R. This AV dissociation, and atrial rate will be faster than ventricular rate. So this is the four things. If you criteria, this ECG fills that four criteria, then this is a complete heart block. This patient needs spacing. That is a treatment, but he will be asymptomatic, and his escape rate is narrower. So it's a relatively stable patient. Can anyone tell the diagnosis? Can you apply the thing I told you just now, four things, and tell me whether it is complete heart block or not, or something else? I think more ECGs to come. Time already 1 hour past. Can hello?
Complete heart block with the broad QRS complex escape.
Yes, yes. Can you apply the four things I told you? Is it correct for this patient?
PP regular, RR regular, more P waves, no definite PQRS relationship.
This is a broad QRS escape. So this broad QRS escape, as already told, is not a stable escape. So this patient needs to be on pacemaker as early as possible. That is the one. So the patient who is having a complete heart block, first thing you have to look for the QRS morphology. That is narrow, so they have stable junction escape or not. So bundle branch escape like LBB, RBB, it's unstable escape. That is the one thing that should tell you that patient is in patient will have problem. And high atrial rate also. The patient will be symptomatic if patient is having high atrial rate. So high atrial rate also indicating patient is in distress and broad QRS escape. And this one is high grade AV block. So atrial rate is high and conduct. This is the one we usually complete heart block with irregular heart rate. We are already told all this RR interval will be same. This is high grade AV block because more 1, 2, 3, 4 atria, more than 2 P waves will be there before the QRS. So there is at least more than 2 non-conducted P will before the QRS, and it will be conducted variably without any P to QRS relation. So that also high grade AV block. That no definition of complete block, but it's high grade AV block. Needs management equal to as complete heart block. It needs pacing, early pacing. It's wide QRS escape. So this is a entity irregularity QRS irregular also. This is a high grade AV block. And this variable it will be conducting. This 3, 4 are there, and in between like that. AV dissociation 3, 1, 2, 3 P waves are not conducted. In 2 way P before conducted QRS they are not conducted. There will be before escape only 2 like that. So this will be high grade AV block. And this is a paroxysmal high grade AV block. There is lot in this patient with some patient we see at least yearly there will have only 1 or 2 episodes of syncope. So in that yearly 1 or 2 episodes syncope is the most difficult thing to diagnose what is the cause. So usually if it is arrhythmic syncope, what there we will put a implantable loop recorder over the chest so that it will record the ECG tracings over the months up to 3 months. And we will explant it and analyze it. Sometimes you will see that high grade AV block like paroxysmal AV block out of sudden without any trigger like PVC or anything or drugs, they will have a AV block. Only P non-conducted P's will be there in trains. So they will have syncope at this point. This is called a paroxysmal AV block. And this is one usually we will see in school children. Childhood episodes of syncope in school, and during the ECG examination you will see sudden slowing and non-conduction of a P wave. This is non-conducted P wave. This is due to vagotonia, usually vagotonia, because after this P wave, conducted P wave, there is slowing of slowing of heart rate. There is broadening of PR interval. So there is definitely vagal effect sets in PR AV nodal PR interval, and there is RR interval increases. So everything increases with the sinus slowing with before the missed P wave, non-conducted P wave, it can be vagotonia. That usually we seen in children who is in assembly had a syncope, come to our casual to our OPD, and in between ECG showing this kind of pattern, sinus slowing and non-conducted P's. This is usually vagotonia. If we can make him walk and again take ECG, then this will go away. This ECG, can anyone see the P wave in this ECG or any other wave apart from P wave? What is the diagnosis of this? P wave is not seen, P wave absent. Then what is the diagnosis?
AF.
AF, correct. In that AF, if usually we will see QRS is RR interval is varying. But in this patient, you are not seeing RR interval is almost constant. And it is bradycardic. Around 9 large squares are there. So the heart rate around 35 or 32 or 33 like that. Low heart rate, but it is regular. Strikingly regular in a patient with AF. It's AF with complete heart block. Okay. AF with complete heart block will have very low heart rate. So they will having heart failure like symptoms like systemic venous congestion or pulmonary venous congestion. So this patient can be improved with medicine as well as pacing. This is AF with complete heart block. AF with complete heart block, strikingly regular heart rate in a patient with atrial fibrillation. Arrows show what? Arrows can only concentrate on the arrow P and QRS relation, and you can tell what is the atrial arrhythmia and what is the AV conduction pattern in this patient. Just to see the arrows, and also the same step 3 and see the what is the atrial arrhythmia going on, and what is the that P wave to the QRS relation. Is it fixed or is it having any conduction abnormality with the arrhythmia like that? This is a combination is to the very brilliant eyes it will be visible. What is there is subtle arrhythmia. You can diagnose these things because atrial flutter is going on. That and below that atrial flutter, anything else is found comparing the P to the QRS relation.
The flutter with the complete heart block.
Correct, very good. Flutter with complete heart block. If this patient, if you DC or give amiodarone, this patient will present you in complete heart block, and with a more symptomatic patient. So this patient you should identify and treat with the pacemaker and ablation, pacemaker and antiarrhythmics. So you should always in arrhythmias you should see the P to QRS relation, fixed or not. Otherwise there is AV dissociation. Now from here onwards, I will be showing the high risk features of a patient who is having a complete heart block, who needs immediate attention in casualty or is. Some people with complete heart block will be very asymptomatic, sitting and scolding us, but some people will be very sick. But you have to find them out. So this is 60-year-old patient had a sudden cardiac death in our hospital, and the ECG in referring hospital was this one. So what was the thing missed? Is it a complete heart block? For this complete heart block, any ischemia pattern is there with the QRS or any other pattern with the QRS? QRS ST segment. We always look for complete heart block for the STT changes as well as T wave abnormalities. So STT changes for you always know this is inferior MI. Is it inferior MI? This is not inferior MI. What is other alarming finding in this patient? With ECG, that will tell he will have some problem immediately. In a patient with complete heart block, this is a complete heart block. This PP is regular, RR is regular, that is P AV dissociation, and this atrial rate is not high, but it's complete heart block. This patient is having prolonged QT in this patient. This patient had prolonged QT. He had a polymorphic VT and sudden and cardiac arrest during transfer. So this patient, this kind of patient with prolonged QT with QT prolongation in patient with complete heart block, you should increase the heart. You should try to increase the heart rate either by pacing at high rates. Not if you pace at slow rates and all, it will be detrimental. High rates, or you should start isoprenalin and atropine, everything, if whatever possible you can do to increase the heart rate, so the QT prolongation will come down. Or if it's a drug-induced QT, that is a different game. That's difficult to treat. You can increase the heart rate with the pacing in that case. So QT segment, it's an analysis of the ST segment for inferior LMI, QT segment for QT prolongation, and the QRS segment for prolonged escape. Is it wide QRS escape? Is important in a patient with a complete heart block. Dinosaur complete heart block alone will not make you will not yield. You have to see more into the QRS, ST segment, QT interval, T wave. This one I think very easy to diagnosis. This what is the ECG abnormality, and two ECG abnormalities are there. Is it reversible or not? Can anyone tell? Is it complete heart block? What is the T wave tell you about the status of the patient? How will you treat the patient?
All TV.
All T wave is hyperkalemia, definitely. Another basic abnormality means the abnormalities. Is it 2:1? Is it high grade, or is it PP interval, RR interval, P2 AV relation, more than R wave.
Complete heart block.
It's a complete heart block. Complete heart block with hyperkalemia. So this patient, if you correct the potassium, he may recover to sinus rhythm. But those patients having complete heart block on beta blocker, all these electrolytes will have a diseased conduction system. So if they revert also in later in a year or two, they will develop complete heart block because of they already their ionic channels and the conduction system are diseased. So this patient may transiently we can put them into sinus rhythm after correcting the potassium. But this patient have inherently diseased conduction system, especially patient on beta blocker. Also, if we see this kind of anomalies like first degree, second degree, high HB, which was reverted after stopping these drugs, but usually they will have a disease the conduction system. They invariably develop a complete heart block later in life. So these patients will be needing, but at this point, the correction of potassium will help him to get out of the crisis. This is another thing some of us will usually come across. A patient with a one ECG showing left bundle branch block. The same patient ECG and another location shows left bundle branch block. This is also alternating right RBB, LBB. This is a conduction system disease, needs spacing at the earliest. Okay, if you same patient having RBB in one ECG, LBB in one ECG, or alternating bundle branch block in ECG is a candidate for pacing at the earliest, is an unstable escape to the complete heart block. This much only. Over. I think you can have a discussion from here.
പാർട്ടിസിപ്പൻസിനെ അൺമ്യൂട്ട് ചെയ്ത് ചോദിക്കാം. വിഷ്ണു 2-3 ECG കൂടെ കാണിക്കുന്നുണ്ടെങ്കിൽ കുഴപ്പമില്ല.
ഇല്ലില്ല, കഴിഞ്ഞു. ഞാൻ ലാസ്റ്റ് ഉണ്ടായിരുന്നല്ലോ. ബേസിക്കലി കുറച്ചേ ഉള്ളു ഇതിനകത്ത് കാര്യങ്ങള്, പക്ഷെ കുറെ ഡിഫറെന്റ് ടൈപ്പ് ഓഫ് ECG കാണിക്കാന്ന് വിചാരിച്ചു, അത്രേ ഉള്ളൂ. അല്ലെങ്കിൽ ബ്രാഡിയാറിത്മിയ മാത്രമായിട്ട് ബോറായി പോകുന്നുണ്ട്.
ഇല്ല, ECG ഉണ്ടെങ്കിൽ 2-3 സമയമുണ്ട്.
ഇല്ല, അത് ഞാൻ ഇത്ര ഇട്ടുള്ളൂ. ഇത് ലാസ്റ്റ് ആയിരുന്നു. ഇനി ഉണ്ട്, പക്ഷെ അത് ഞാൻ ഇതിനകത്ത് ഇൻക്ലൂഡ് ചെയ്തിട്ടില്ല. അത് കുറച്ചും കൂടെ ഇത് തന്നെ കുറച്ച് ഡിഫിക്കൽട്ട് ആണോ എന്ന് എനിക്കൊരു സംശയമുണ്ട്. എന്റെ കൂടെ നമ്മളെ ബേസിക് ആയിട്ടുള്ള സാധനങ്ങൾ അറിഞ്ഞിരിക്കുക, അതിന്റെ കുറച്ച് വാർണിംഗ് സൈൻസ് അറിഞ്ഞിരിക്കുക എന്നുള്ളതാണ് ഞാൻ ഉദ്ദേശിച്ചത് ക്ലാസിന്റെ.
യൂസ്ഫുൾ ആയിരുന്നു. പാർട്ടിസിപ്പൻസ് ക്വസ്റ്റ്യൻസ് എന്തെങ്കിലും ചോദിക്കാനുണ്ടെങ്കിൽ തീർച്ചയായിട്ടും ചോദിക്കാം. നമ്മളെ
ഞാൻ കുറച്ചുകൂടെ പ്രാക്ടിക്കൽ ഓറിയന്റഡ് ആയിട്ട് എന്തൊക്കെ നോക്കണം എന്നുള്ളതാണ് ഉദ്ദേശിച്ചത്.
നന്നായി മറ്റേ
തിയറി ആകുമ്പോൾ നമുക്ക് എല്ലാവരും കേട്ട് ഈ സെക്കൻഡ് ഡിഗ്രി തേർഡ് ഡിഗ്രി വെരി കോമൺലി നമ്മൾ കാണുന്നതല്ലേ. അപ്പൊ അതിനകത്ത് നിന്ന് കുറച്ചുകൂടെ വ്യത്യസ്തമായിട്ട് ഇമ്പ്രൂവ് ചെയ്യാനായിട്ടുള്ള എന്തെങ്കിലും ഡൗട്ട് ഉണ്ടെങ്കിൽ എനിക്ക് പിന്നെ മെയിൽ ചെയ്താലും
ചോദിക്കുന്നുണ്ടെങ്കിൽ തീർച്ചയായിട്ടും ചോദിക്കൂ. ഇല്ലെങ്കിൽ നമുക്ക് വൈൻഡപ്പ് ചെയ്യാം. ചാറ്റ് ബോക്സിൽ ക്വസ്റ്റ്യൻസ് ഒന്നും വന്നിട്ടില്ല. ഡയറക്റ്റ് ആയിട്ട് ആർക്കെങ്കിലും ചോദിക്കണം എന്നുണ്ടെങ്കിൽ
കുറവായിരുന്നു. അതുകൊണ്ട് പിന്നെ ഞാൻ പറഞ്ഞു കുറച്ച് ഡിഫിക്കൽട്ടി ടൈപ്പ് ആയിരിക്കും ഇനി അങ്ങോട്ട് വരുന്നത്.
ആർക്കെങ്കിലും ക്വസ്റ്റ്യൻസ് ചോദിക്കാനില്ലെങ്കിൽ നമുക്ക് സെഷൻ വൈൻഡപ്പ് ചെയ്യാം. എല്ലാവരും താങ്ക് യു ആണ് അടിക്കുന്നത്. ഇൻഫോർമേറ്റീവ് ആണ്, താങ്ക് യു ആണ്, അങ്ങനെയാണ്. പിന്നെ ഇതില് അവർക്ക് ഡൗട്ട് ആർക്കെങ്കിലും അൺമ്യൂട്ട് ചെയ്ത് ചോദിക്കണം എന്നുണ്ടെങ്കിൽ ചോദിക്കാം കേട്ടോ. ECG ബേസിക്സ് ക്ലാസ് നീഡഡ് ആണ് പറഞ്ഞത്. അപ്പം ബേസിക്സ് ക്ലാസ് നമ്മൾ ആദ്യം ഒന്ന് എടുത്തായിരുന്നു. നമ്മുടെ ഫസ്റ്റ് സെഷൻ ബേസിക്സ് ആയിരുന്നു.
ഡൗട്ട് ഉണ്ടെങ്കിൽ എനിക്ക് എടുത്ത് അപ്പൊ തന്നെ അൺമ്യൂട്ട് ചെയ്ത് ചോദിക്കാവുന്നതാണ്. അപ്പൊ ഞാൻ അത് പറയായിരുന്നു. കാരണം നമ്മൾ ഓരോ ഇതിലും പോകുമ്പോൾ കുറച്ച് ഒന്ന് ബിൽഡ് ചെയ്താണ് പോകുന്നത്. ഓരോ പുതിയ ഇൻഫർമേഷൻസ് ക്ലിനിക്കലി എങ്ങനെ പേഷ്യന്റിനെ റെസ്റ്റാറ്റിഫൈ ചെയ്യാം, അതാണ് ബേസിക്കലി നമ്മള്.
അല്ല, ഏതായാലും വിഷ്ണു ക്ലാസ് യൂസ്ഫുൾ ആണെന്ന് വെച്ചാൽ സാധാരണ ECG ക്ലാസ് എടുക്കുന്നവർ ആ ഫൈൻഡിങ്സ് കണ്ടു കഴിഞ്ഞാൽ എന്ത് ചെയ്യണമെന്ന് പറയാറില്ല. വിഷ്ണു എന്ത് ചെയ്യണമെന്നുള്ള നെക്സ്റ്റ് സ്റ്റെപ്പ് പറയുന്നുണ്ട്. അതാണ് പാർട്ടിസിപ്പൻസിന് കൂടുതൽ യൂസ്ഫുൾ എന്ന് ഞാൻ മനസ്സിലാക്കുന്നു.
നമ്മൾ കംപ്ലീറ്റ് ബ്ലോക്ക് കാണുമ്പോൾ നമ്മൾ എല്ലാത്തിലും പേടിക്കേണ്ട കാര്യമില്ല. ചിലത് നമ്മൾ വളരെ ശ്രദ്ധിക്കുകയും വേണം. അപ്പൊ നോക്കേണ്ട കാര്യങ്ങൾ ഓട്ടോമാറ്റിക്കലി QRS അങ്ങനെ ആ ഒരു പാറ്റേൺ നമ്മൾ ഓർത്ത് പഠിച്ചു കഴിഞ്ഞാൽ ഓട്ടോമാറ്റിക്കലി അത് നമുക്ക് വരും. അപ്പോൾ അതാണ് വിൽ ബി മോർ യൂസ്ഫുൾ എന്നാണ് എനിക്ക് തോന്നുന്നു.
ആരും ഡൗട്ടൊന്നും ചോദിക്കുന്നില്ലെന്ന് തോന്നുന്നു. നമുക്ക് അങ്ങനെയാണെങ്കിൽ വൈൻഡപ്പ് ചെയ്യാം. നമുക്ക് വൈൻഡപ്പ് ചെയ്യാം വിഷ്ണു.
ഓക്കെ ശരി.
വേറെ ആരും ചോദിക്കുന്നില്ലെന്ന് തോന്നുന്നു.
ഓക്കെ, എന്തെങ്കിലും ഡൗട്ട് അടുത്തതിലൊക്കെ ആയിട്ട് അല്ലെങ്കിൽ വാട്സാപ്പിൽ എല്ലാം കൂടെ കളക്ട് ചെയ്തിട്ട് ഞാൻ തരാം.
But thank you very much, Dr. Vishnu, for sparing the time after a hard day's work. Thank you for all the participants who attended this session for the quest of knowledge. Thank you very much. We'll come with another session soon. Thank you very much, participants. And on behalf of KGMOA Academic Cell, I thank you, Dr. Vishnu. Thank you very much.
Thank you, sir. Thank you.
Good night, Dr. Vishnu. Good night to all.
Good night.